Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Summary of Standard Medical Textbooks. Today, let us discuss one more important topic in respiratory failure, that is ARDS, Acute Respiratory Distress Syndrome. Let's begin with the name of Allah. So, what's the definition? What is ARDS basically? ARDS is nothing but it is a type of respiratory failure. It is acute respiratory failure which is life-threatening. So ARDS is a life-threatening form of acute respiratory failure. Life-threatening form of acute respiratory failure is known as acute respiratory distress syndrome. Okay, and remember, this does not respond to oxygen therapy. Does not respond to oxygen therapy. If you have seen the last video on the interpretation of ABG based on the context of respiratory failure, then you will be knowing that when SiO2 is decreased, meaning the pulse oximeter is showing hypoxemia, and when you perform ABG and A minus A2 gradient is normal, and then PaCO2 is also either normal or it is decreased. In these cases, you will give oxygen therapy to the patient, 100% oxygen therapy to the patient. So if the patient responds to 100% oxygen therapy, then the causes can be airway causes and alveolar causes or vascular causes. Okay, so response to 100% oxygen therapy indicates that the acute hypoxemia is not that severe. So, but if the patient doesn't respond to 100% oxygen therapy, then we have learned that there is massive pulmonary edema. So this is that case where the patient doesn't respond to the 100% oxygen therapy because of very massive intrapulmonary shunts, meaning the alveoli are filled with fluid, but the blood is passing without oxygenation. So that is ARDS. That is ARDS. After reading many of the textbooks, what I have learned is it is a stage between hypoxemic respiratory failure and hypercapnic acute respiratory failure. So before progressing to acute hypercapnic respiratory failure, first the acute hypoxic respiratory failure passes through the acute respiratory distress syndrome. Okay, so acute respiratory distress syndrome will not correct with 100% oxygen therapy. That you should remember. So what it is a life-threatening form of acute respiratory failure. So how do you recognize this? By 4 conditions. Berlin definition of ARDS 2012 Berlin definition of ARDS. If 4 conditions are present, then you will say that patient is in ARDS. The onset of this should be respiratory failure should be within 1 week of known clinical insult, or new or worsening respiratory symptoms should be there. The onset should be within 1 week, or if already it is there, then there should be if it is not there, there should be a new onset, or if it is there, there should be worsening of the symptoms within 1 week of known clinical insult. Okay, that is one condition. Second condition is there should be bilateral opacities on the chest X-ray or CT scan, meaning there should be bilateral whiteout lungs, which should not fully explained by effusions, lung or lobar collapse or nodules. Okay, that opacities, bilateral opacities are not you can't explain those opacities. They are not due to pleural effusions or collapse or nodules. They are due to something else. So bilateral opacity should be present on radiological investigation. That is the second condition. Onset within 1 week and bilateral opacities not explained by all those. Then respiratory failure not fully explained by cardiac failure or fluid overload. Okay, so there is pulmonary edema in acute respiratory distress syndrome. Because of that massive pulmonary edema, there is ARDS. So the pulmonary edema can be either due to ARDS, or it can be due to cardiac, or it can be due to fluid overload. So the cardiac cause and fluid overload cause should not be there. That should be excluded. Objective assessment is done by echocardiography. This must exclude hydrostatic edema if there is no risk factor present. Especially this echocardiography will help in excluding cardiac cause of edema if there is no risk factor for ARDS. Okay, this is the third condition. So that pulmonary edema should not be due to, that should not be a cardiac pulmonary edema, or that edema should not be due to pulmonary fluid overload. That is the third thing. Fourth is there should be impaired oxygen such that PaO2 by FiO2, fraction of inspired oxygen, should be less than 300. less than 300. Okay, so these four conditions, when they are met, then we will say the patient is in ARDS. Onset within 1 week, bilateral opacities on the investigations, not explained by effusions, nodules, or collapse, and pulmonary edema not contributed by heart or fluid overload, and impaired oxygenation should be there. Ratio should be less than 300. So how do you see the severity? How do you gauge the severity of this ARDS? Okay, how severe the ARDS is. This is important for type of respiratory. You need to know this in order to know the prognosis also, and to know the type of respiratory which the patient requires. So severity of hypoxemia is calculated using a PO2 by FiO2 ratio. This is a number calculated by using a PO2 from an RTL blood gas measurement divided by the fraction of inspired oxygen, expressed as a fraction. For example, a patient with PO2 of 10 kilopascals, meaning 75 millimeter of mercury on 50% oxygen, that is FiO2 of 0.5, would have a PA by FiO2 ratio of 20 kilopascals. That is nothing but 150 mmHg. This should define a moderately severe ARDS if the other Berlin criteria were met. The severity will assess only when you confirm ARDS. So, and one thing is, all measurements should be taken on a minimum of 5 centimeter of water of PEEP or CPAP. PEEP is nothing but what do you call, peak and expiratory volume. So peak and expiratory pressure, the pressure which you apply on exhalation, that is, so minimum that should be 5 centimeter, equal to or more than 5 centimeter of water. That PEEP should be there when you are measuring PaO2 and FiO2, and that fraction should be less than 300 mm of mercury, or less than what do you call, less than 300 of mercury it should be there. Okay, so now based on that, mild it is said when it is 300 to 200, moderate if it is 200 to 100, and severe if it is less than or equal to 100. So that is how you calculate the CRT. Key point to note here is ARDS is a syndrome, it is not a disease. It arises from diverse triggers. These are the commonest causes: sepsis and pneumonia. These are the very commonest causes of ARDS. So you have some setup, but you don't have the facilities to calculate ABG. Okay, so how do you know that the patient, and you don't have ventilation also, so you don't know PEEP, because PEEP you will know when there is HFNC, at least HFNC and or mechanical ventilation, so you will know the PEEP. But PEEP is not there, no, you don't have all those things. How do you know? So there is, for knowing that, there is Kigali's modification of that ratio in order to diagnose ARDS in patients in areas where facilities are not available. So it is just SpO2 saturation, pulse expiratory, in percentage divided by FiO2 in fraction. If this is less than 315, then that patient has ARDS. Okay, this is proposed for use in resource limited settings. So that's, you have diagnosed and you have known the severity of ARDS also. Now we will move forwards. So that Kigali's modification, its goal is to allow the diagnosis of ARDS in non-ventilated patients who do not have arterial blood gas measurements. So that's about severity and diagnosing. So what is the pathophysiology? What are the etiologies of ARDS? It can be a direct injury or indirect injury. Indirect injury: pneumonia, aspiration, drowning, inhalation injury like some fire, lung contusion, or sepsis, shock, disseminated intravascular coagulation, pancreatitis, trauma, transfusion associated lung injury, also known as TRALI. So these are the direct and indirect causes of ARDS. Most common among these are these three, as shown in this box also. So pneumonia, aspiration of gastric contents, and sepsis account for more than 85% of ARDS cases. Okay, now we will understand the pathophysiology of this. So this is one diagram. So causes can be pulmonary or non-pulmonary. Most common: pneumonia, aspiration, and sepsis, or but transfusion, all these causes. So these are the risk factors, or you can say this as cause also. These will be there. And patient factors or patient comorbidities, genetic factors and comorbidities, like alcoholism, patient is alcoholic, patient is having diabetes, patient is smoker, or patient is obese. So these also contribute to the development of ARDS. alcoholic patient or smoker, or diabetic, alcoholic, smoker, and obese patient. Other factors like infection, VAL is nothing but ventilator associated lung injury, transfusion associated lung injury, fluid overload. All these contribute to inflammation, coagulation, altered cell function, tissue injury, and finally fibrogenesis and repair. So these are the factors. So these are the you can these two are iatrogenic. You can see these three. These are iatrogenic factors: ventilation, transfusion, fluid overload. Fluid which you give IV, and transfusion which you do if the patient requires, and ventilation which you give for as a respiratory support. So these also contribute, if these are not adjusted properly, these also contribute to ARDS. Okay, so these are all risk factors for ARDS: genetic and comorbidities, and these four, and these pulmonary and non-pulmonary causes. These are all risk factors you should have in mind ARDS if these are there. Okay, in the patient. Etiology of the ARDS: a combination of patient factors, genetic and comorbidities, and iatrogenic factors like this. These are all iatrogenic factors contribute to the pathological processes of ARDS. So this will be the initiating event. So you can divide the ARDS. Actually, ARDS is a phase from which the lung passes through. You can't treat ARDS. You can't treat ARDS. Okay, ARDS has no treatment at all. So you need to treat the cause, and you need to give the patient respiratory support till the patient passes through this critical stage, till the lungs passes through this critical stage. Okay, so that's all. So what are those stages through which the lungs pass? So first one is injury phase. First is injury phase. Direct or indirect causes will cause endothelial or epithelial damage. Example, so this will cause endothelial or epithelial cells of the alveolar. They will cause damage. That will that chingari will induce fire. Okay, so that fire is nothing but inflammation. So due to inflammation, cytokines like interleukin 6, tumor necrosis factor alpha will call neutrophils. The treatment is nothing but they will call neutrophils, and neutrophils will again produce these factors, and they will call further more inflammatory cells, and finally these cells will release proteoses and react to oxygenation species. So they fight actually the insult which is happening to the lungs, because the inflammation is so high, there is a very high collateral injury to the lungs which is going on. That's why this ARDS develops. So what happens then? Then there will be increased alveolar capillary permeability. That leads to protein-rich fluids leaks into the alveoli. Inflammation will cause increased permeability. That will cause protein leak into the alveoli. Okay, then there will be the edema formation. Okay, that is exudative phase, and this is edema formation. Okay, this is also known as proliferative phase. Okay, so that is exudative, this is proliferative. Fluid fills the alveoli. That leads, now alveoli are filled with fluid. Okay, but blood vessels are normal. Okay, and here also there is fluid, so no oxygen. So blood passes like this only without any oxygenation. Okay, so that causes VQ mismatch and shunt, intrapulmonary shunt. Shunt is nothing but bypassing. Alveoli are filled with something else than oxygen, so blood is not oxygenated. And apart from filling the alveoli with this fluid, there is surfactant dysfunction, because this inflammation will destroy type 2 pneumocytes which will produce the surfactant. Okay, so because the surfactant is lost, surface tension of the alveoli is lost, they will collapse. So atelectasis will occur. So so this will cause increased dead space of the lung, dead space. So the normal the alveoli will collapse, so air will not be there, the dead space will increase. Okay, so the next phase is the fibrotic phase. If severe, there will be fibrosis of the lungs. So fibroblasts will come, they will proliferate and cause lung fibrosis, and this will appear as honeycombing on imaging. So this is a picture which shows the inflammation in the pathophysiology of ARDS. See, this is the normal lung, this is the surfactant, this is epithelial basement membrane, type 1 cell, interstitium, RBC, this is the endothelial cell, endothelial basement membrane. But when there is injured alveolus during the acute phase, there is sloughing of bronchial epithelium. Okay, so because there is injury to the alveolar epithelial cells and endothelial cells, so inflammatory cascade will be activated, and that will so there'll be gap between the endothelial cells. So this inflammatory cells will enter, and they will release proteases which will cause damage. Now because there are gaps are produced in between the endothelial cells which are damaged, so there'll be leakage of fluid. Because there is inflammation, there will be leakage of fluid, exudative fluid, and that fluid will enter the alveoli also. So neutrophils and macrophages, all these will call furthermore inflammatory cells, and also they will uh, release some proteins which will cause collateral damage to the alveoli. Along with the, if they become severe, fibroblast will come, they will cause fibrosis like this, procollagen they will secrete. Okay. And if severe, the patient can also go into DIC, disseminated intravascular coagulation, okay, where platelets are consumed. There can be chances of bleeding also, there can be chance of coagulation also. Bilateral sword, you could call it as, no. So this is a picture which depicts the pathophysiology of ARDS. Now this is important. So this is a diagram which shows normally the ARDS will go up to 21 days maximum patients. Okay. The exudative phase is notably for early alveolar edema and neutrophil-rich leukocyte infiltration of the lungs, with subsequent formation of hyaline membranes from diffuse alveolar damage. Within 7 days, a proliferative phase ensues with prominent interstitial inflammation and early fibrotic changes. Approximately 3 weeks after the initial pulmonary injury, most patients recover. However, some patients enter the fibrotic phase with substantial fibrosis and bullae formation. So up to 7 days will be the exudative phase. Okay. From 7 to 21 days, so the alveoli will be filled with fluid, there will be interstitial inflammation, plus there will be some early fibrotic changes, and most of the patient will recover in 21 up to 21st day, meaning 3 weeks. Some of the patient will progress on to develop after 3 weeks. They will enter into fibrotic phase, where the lungs will get fibrosed, meaning the functional lung tissue, that is nothing but parenchyma of the lung, is lost. Okay. Parenchyma, similar to other chronic diseases like chronic kidney disease, where the parenchyma of the kidney is lost. Okay. Heart, in infarction, if you don't intervene early, then parenchyma of heart is lost. So this is a any organ which shuts, no, any important organ which shuts, it will shut in 2 ways. Either it can be acute shut, or it can be chronic shut. When there is acute shutting, so that organ, that vital organ which will shut abruptly, abrupt shutting of that organ. But when it will, if you intervene early, it will recover completely, like AKI, patients with AKI. Example, patients with AKI or ALI, acute lung injury, okay, or acute heart failure, all these cases. Okay. But in these cases also, if you intervene late, then that organ will recover, but there will be some parenchyma will be lost from that vital organ. In chronic cases of lung injury, what happens is, if you intervene also, there is that may slow down the progression of the damage to the parenchyma of that vital organ, but that vital organ will go on progressing days from months to years, and finally after some years that vital organ will cease to function. That is nothing but chronic organ disease. So you can't halt that progression completely. So patient will move on to the slowly patient will move on to the cessation phase of that vital organ. Okay. That is nothing but chronic organ, like chronic kidney disease, or chronic lung disease, or chronic heart failure. All these, okay, these are the two types of in these two manners the organs will fail. Okay. That's just one, just to have that information, basic information. So these are the stages by which a lung passes. So what will be the consequences? So I said, no, because the alveoli are filled with fluid, so lung will blood will bypass the alveoli, and there will be complete blockade. There will be hypoxia because of VQ mismatch, because of intrapulmonary shunt, and some alveoli will collapse like this. Why they will collapse? Because of surface tension. So so to open that alveoli and to press this fluid backwards and to give oxygenation to this affected alveoli, you need to give PEEP. PEEP is nothing but peak end expiratory pressure, peak and expiratory pressure. So what this does is this will open the closed alveoli, because most of the alveoli is closed during expiration. So at that time you are applying some pressure while giving oxygenation. So the closed alveoli will get opened, and this filled the alveoli which are filled with fluid. So this fluid will be pulled back because of that pressure. So some alveoli you will get from this also. That's how you will improve oxygenation in these cases. Okay, and there will be increased dead space fraction. Dead space will be increased. There will be alveoli which are having oxygen, but in this case ARDS, alveoli are filled with the blood oxygenation. Q is normal, but V is very much abnormal. So there is increased dead space fraction of the lung. Now because the lungs are edematous, so imagine the lung is a balloon. Okay, it is already inflated by fluid, or there is no surfactant and alveoli are collapsed. So this will reduce the compliance, stretchability of the lung, stretchability of the alveoli. Stretchability of the alveoli will be reduced. This will be the result. Okay, so there will be shunt and the decreased compliance of the alveoli. Okay, how do you measure the compliance? You will measure the compliance by this formula: tidal volume divided by plateau pressure. Plateau pressure, what is? I will explain what is plateau pressure. Minus peak and expiratory pressure. So this will give you the compliance of the lung. Okay, and in cases of ARDS, to have a good outcome, you should keep this compliance of the lung less than 50 ml per centimeter water. 50 ml per centimeter of water. Okay, what per centimeter? That's just remember the thing. Okay, now coming to the clinical features of ARDS, we will discuss investigations and management in the other video. Just we'll discuss now the clinical features. So what will be the symptoms? There will be dyspnea, of course, it is a type of respiratory. There will be tachypnea. This one point, hypoxemia, which will be refractory to the oxygen, 100% oxygen. Okay, and on examination you will have crackles, increased work of breathing, and in late stages you can have bluish discoloration of skin and mucous membrane also. That is nothing but cyanosis. So we have completed the definition of ARDS, what is basically ARDS, and what are the causes of the ARDS, pathophysiology of ARDS, and stages of ARDS, and how do you recognize ARDS, and what are the clinical features of ARDS. Investigations and treatment will be discussed in the next video. Thank you for your listening.